Ladies and gentlemen, welcome back to Soft Tissue Management Part B. I'm Markus Troeltzsch, and maybe you remember that was the last thing we were talking about in Part A. You have the flap, you position it directly into the wound, and you put in the first suture at the position where you want your flap to be, just to make sure you have the position. The first suture has most tension on it, so you fix that, and afterwards you align your sutures around. Then you have your wound closed. Now, we have been talking about the simple knot techniques, but there's more to it. Very often we want more stability in our wounds, and that's when we perform the so-called mattress sutures. And mattress sutures are something very easy once you understood the principle of it. For mattress suture, you start like doing a simple suture. You go through the first side, 90-degree angle, you rotate your needle through it, you come out of it, you reposition your needle, you go through the second side, and there you go. You pull your cord gently through it, you have a short part and a long part, and what you do now? You just go back and you start at the side that you've left last. You enter there again, you go directly in the same height on both sides, you pull through, and there you are. Now you have a loop like a U. And with this you have a very good force distribution in your tissue, and the risk of it ripping apart is a lot less, and it gives the whole tissue a lot more stability than a just simple knot. Of course, knotting it is still the same as we would be talking in Part A. And here you see some clinical examples of mattress sutures. On your left hand side it's a bisphosphonate case. You see a lot of mattress sutures keeping the wound very closed. And on the other side, even more sutures. That is an augmentation procedure after a huge cyst. We have a lot of bone in there, and we do not want this wound to open, for the bone to be stable. Now, how do we close papilla sutures? You remember in Part A we were talking about the advantages of a marginal approach, and for marginal closing you need papilla sutures. Well, a papilla suture is nothing but a mattress suture. It is just a vertical one. So the technique of a papilla suture is very easy actually, it just needs a little bit training. You start vestibulary. You go through your tissue quite apically, more apically than you would if you would just go through it. And then you leave with your needle on the lingual side. You pull your cord through like you would do for a normal mattress suture. And on the lingual side, you go through more coronally, as you can see here. And then on the vestibular side, you leave it more coronally as well. So in the end, your papilla suture looks like this. Now let's go back to our orange for training purposes. And that is like the perspective that you would have in the oral cavity as well. So you don't really see where your needle goes. You go through it, you rotate your needle through it again, you pull it through, you change the direction, and you come back from the lingual side. This is one of the reasons where you might decide for a straight and not for a curved needle, just for getting through easier. I, for myself, prefer still the curved needle, but that's up to your personal taste. And as you can see here, we don't see anything. We really don't see how to do it. So allow me to give you a coronal aspect to it. Again, orange model and of course orange teeth. And here you see the papillar suture in place. How was it done? Well, arrow number 1 is the part where you go from the vestibular side to the lingual side through it. And part number 2 is where you come from the lingual side and go back through it to the vestibular side. And then you see why it's a horizontal. On the lingual side, you can see the cord coming out apically and going back into the tissue more coronally. You just put in your knot as you're used to be doing it, and you have a very good wound closure. It's very tight, has a very good bleeding control. Papillary sutures are something very helpful, and here you see them in place. You can see if you look at the position of the gums that it's really where they should be. So with a little bit of training, it's very easy to reposition your papilla where it should be. And the scarring happens between the teeth and pulls the tissue a little bit more coronally. so the risk of recession is really not that high. Very good technique, absolutely easy to learn. And after we've been talking about these oranges and simple cases, allow me to show you a little bit more advanced technique. In this case, we have to take this first molar on the upper left side out. Now, we know from our x-rays that there's an issue with the sinus. And after performing our marginal incision and our relieving incision, we prepare our flap. Remember, we start apically with our elevatory and then just coronally move our flap away, and then you have this picture, and you see after taking the tooth out the big defect of the sinus. So in this case we really need tight wound closure, apart from telling the patient not to blow his nose, and of course we need antibiotics in this case, but that's a little bit off topic. So in this case you want tight wound closure. And how do you do it? After I close the relieving incision in the front, I see that there's really no way how I can totally close that up. So the next step is you try to mobilize your flap, you see it doesn't work, then you go for another relieving incision around the second molar. And allow me to illustrate that a little bit more. The wisdom tooth is missing, and in white indicated is our first incision line. Now we take that tooth out and see that we can't close the wound anymore. The next step is the new relieving incision, again in white as you can see here, and we mobilize our flap. How do we do it? Well, exactly as we've been seeing it in part A. You go in and cut through the periosteum, and then you pull your flap. And then it gets very easy. So allow me to go back to the clinical case. On the left you see the flap and the dot in green. And that is exactly the position where you start pulling after you cut through your periosteum. You pull it and you pull it close. You put in your sutures again at the tip of your flap as we've been seeing it in part A and also at the beginning of this lecture, and then you put in all your other sutures. And you see it has a very, very tight seal around the second molar, and the pupillary sutures between the premolars keep it perfectly in place. The picture through the mirror shows you the green dot again, how far we moved it without putting too much stress on the flap. So that is the basic technique that gives you the ability to handle most flaps in the oral cavity. But what's with the complications? And we all know that surgery itself is not that hard. About anybody can do it as long as everything goes fine. The problem is to be able to handle your complications. Now, one of the complications we get asked about a lot in our courses is what happens if I cut through my flap? Well, now here, as an example indicated with the white line, just imagine you cut through your flap here while going through the periosteum. Well, in this case, we just sew the injury tight as it was a second wound and continue as planned, with the one example difference. Here we want oral disinfectants and here we want antibiotics, as there's a certain risk of the flap going necrotic, especially in the coronal area. If the injury occurs more coronally than indicated here, then you could also try to just mobilize more gingiva and sacrifice the part that is coronal from your cut and still perform a normal flap procedure. But both ways will work, especially if you have to work with the flap you had and you just apply oral disinfectants and antibiotics. Well, what happens if I have bleeding afterwards? This is again a case that came into our clinic as an emergency. You can see the hematoma and the coagulum and all the blood in the oral cavity. It came from an osteotomy site where no flap had been performed. So what do? You take a hemostatic agent, a resorbable one, there's lots of them on the market, and you put it in there. And these hemostatics, you want to push them in there tightly. This allows the hematoma to organize itself better and it blocks further bleeding. And as a next step, you mobilize your flap as I showed you in the first case. You have a simple gingiva mobilization. You just go in with your elevatory, you go in between your bone and your periosteum, you cut through your periosteum and then you pull everything shut. In this case, we didn't even need any relieving incisions to keep the wound as closed and as small as possible. So with this, it's fairly easy to control bleeding. As a last resort, if you just cannot handle the bleeding, then you take an analginate impression, put it in, and leave it there dry. And leave it in there for an hour and then take it out again. This usually stops all bleeding as the alginate contracts while getting hard. Now, if this still didn't stop it, then you put another alginate and send the patient to a clinic for oral and maxillofacial surgery for further procedures. If you want to assess your wounds, you have to know how they should look like. This is a normal result after about 5 to 7 days when we took out this suture for a simple tooth extraction. This is a normal healing condition. Another normal healing condition is this. You see there had been a flap performed in the anterior area. You still see the scar. This is after about 4 weeks. This is a very good result. This is normal. You still have the scar of the crestal incision, but this is normal. But what do you think about this? This is after 3 weeks, and you still see it's a little bit strange. Now in this case, we had taken several anterior teeth out, and the patient went back to his dentist and had the prosthesis changed a little bit. However, with the first impression that they took it on the day of the extraction, and so they had too much material at the base of the prosthesis, and what you can see here is nothing like an ovic pontic effect. They formed papillas, what you don't want in this case. So the resolution for this was just to adapt the base of the prosthesis to the way it should be, and to go through this area a little bit, maybe with a scalpel or a sharp elevatory, just to rub away the gingiva a little bit, and the healing will be fine. Here you see pus. That's a fistula, that is a manifest wound infection, and you definitely want it to be that way. This is a result after a week, and there's a wound infection going on. And if you look at this picture, you have more or less the same in the upper jaw here, the arrow indicating a fistula. However, this fistula was even going through to the sinus. So how do you handle these cases? Well, the first step is always the antibiotics and the oral disinfectants, and you do that for 5 to 7 days. And in quite some cases, this is already sufficient to fight the infection, and then the body will take care of itself. Well, if it didn't, you will have to go for another surgical procedure to cut out the fistula and to clean the site, to open it again, perform cleaning procedures, and then close it properly again. However, you want to do that after the acute infection has vanished through your antibiotics and oral disinfectants. And that is an effect that you can see happen sometimes. This is a result after 3 weeks, both of them approximately 3 weeks. This is not normal. This is a local infection again, sort of a wound irritation or a chronic infection of the site where the tooth was in. And again, the performance is you put in cleaning, oral disinfectants, and antibiotics. And what is the cleaning in this case? Well, you apply local anesthesia, and then you go in with a root elevatory and rub over the bone until you have profound bleeding, and then you let it go. This usually will solve the case again, as you have a fresh wound condition. If this didn't work and after 2 weeks there's still a problem, you want to refer that patient to an oral maxillofacial surgeon, as there might be a total different cause underlying for that whole situation. So allow me to start finalizing part A and B of this lecture. Our take-home messages are: please be aware of the anatomy, especially of your nerves. When performing soft tissue surgery, the nerves is what can get in your way. If you're not very experienced, if you're still learning it, or if you just want very complication-free procedures, then the marginal approach has a lot of advantages. And as indicated during the course of these lectures, the correct handling of the instruments makes everything doable. Most of the problems that especially beginners occur is due to not holding the instruments in the right way. Now, all the surgery, you can learn it from textbooks or lectures, but the only thing that really helps you is training it. That's why we have the orange model. You can perform that at home alone while looking at the lecture. Very easy for you. The other thing is to attend hands-on courses. We do have one, but there are so many hands-on courses out there. Don't hesitate, go to them, and you'll see there's a huge training effect through that. Allow me to thank you for your kind attention. There's more lectures in this series of basic principles of oral surgery, and thank you for looking at us, looking at our lectures in the Dental Online College. Thank you very much.